and I know that you probably can comment on some of the data with even ibrutinib in follicular lymphoma. It seems some very exciting developments there too. So the role of these kinase inhibitors in that disease.
Right. So even ABT-109, there's a follicular lymphoma study. So a lot of the very exciting novel agents as showing activity in CLL are now being translated into other indolent lymphomas.
Exactly.
I think the interesting thing is the dichotomy between the two diseases, and perhaps in follicular lymphoma you see more LFT abnormalities with the PI3 kinase inhibitors, where the immune system is more intact. So one can translate some things from one disease to the other, but in one disease sometimes toxicity will be more frequent. But it is really exciting that we have all these new agents coming forward. And
I think that's true. I mean, the use of lenalidomide in patients with either follicular lymphoma or diffuse large cell lymphoma, I am impressed. You could start with 15 milligrams without even blinking an eye, and some protocols call for even higher amounts. So obviously amounts of lenalidomide that if you gave to a patient with CLL would cause major problems. So there is differences in how patients will tolerate this, and I'm intrigued by these protocols involving rituximab as well as the lenalidomide, the so-called R-squared, as you mentioned, in combination with your chemotherapy. I think you're going to have some time to talk about some of those regimens too.
Yeah, I think that one of the abstracts that are going to be presented to this meeting also, it's a little different. So with the upfront setting, I think that really BR has taken the major role right now. But it was interesting that Matthias Rummel actually had an abstract that's going to discuss the data from an 8-year follow-up in non-Hodgkin's lymphoma, looking at bendamustine Rituxan versus fludarabine Rituxan, which we used to use, and John worked a lot with respect to CLL from the CLGB protocol. And it does work also in indolent lymphoma, and we're talking right now with follicular. But it's interesting, they did this study and they have an 8-year follow-up in relapsed follicular lymphoma, but they also, I think it's very interesting when I see some of the data that actually comes from Germany, because they don't just use follicular. I think it's interesting, it's follicular, Waldenstrom's, and they also include mantle. So I guess you get more publications if you study a bunch of diseases and then just do subgroup analysis. But I just wanted to comment on this study. They looked at that the patients that we could predict is that, it's not FCR, it's FR. FCR is more active, or using an anthracycline, or like for fludarabine, mitoxantrone, or rituximab. But in this study, what they did show is a median follow-up, again, 96 months, is that everything favored bendamustine Rituxan. The objective overall response rate was 83 versus 52%. A little bothersome, but maybe in a relapse setting. The median number of prior treatments for this group of patients was only 1. So it seemed that, at least in my experience, giving FR after, say, R-CHOP, I had more than half the patients actually had a response. But again, this was in a larger number of 230 patients. The CR rate was only 38% versus 16% BR versus FR. And then the median progression-free survival, 34 months with BR versus 12 months. Again, usually I get more mileage out of FR. The only thing I wanted to mention when you actually look, they say the devil's in the details, is that the plan was treating with 6 cycles was the median number. But again, they don't go through subgroup analysis. I mean, this is with the overall. I think it's important, and maybe this will be when it's presented. I want to see specifically what happens to the follicular, to the patients perhaps with other indolent marginal, to the mantle cell, to the Waldenstrom's. I know when you group them all together, there could be differences that are not clear. But 6 cycles, 75% of patients with the BR only got 6 cycles. And it was interesting, 53% of the FR patients received 6 cycles. So there's a little bit of an imbalance in the number of treatments, that the patients getting 6 cycles of therapy, maybe 50% higher got 6 cycles of BR than the FR. So that actually could influence some of this data. I just bring it up because what do you do? And a lot of people are using BR up front. We're not going to reuse it. Typically, I would not reuse the same agents with the world that we live in today. We can use other agents, but this was in a different time. This was in the past. But I thought I would just mention it. I think we should, to move on.